Hello everyone and welcome to our module on valvular heart disease. Lesions of the cardiac valves come in two forms. The first is stenosis. So when valves in the heart become stiff and thickened, the valve leaflets do not open and move normally, and this causes an obstruction to forward blood flow, and that's what we call valvular stenosis. In contrast, when a valve develops regurgitation, there's malcoaptation of the leaflets. And by this I mean that the leaflets don't come together normally and form a seal. As a result, blood can leak backwards across the valve, and that's what we call regurgitation. For stenosis, there's basically only one way that stenosis presents, but for regurgitant lesions, there are two ways in which they can present. One is the acute form and one is the chronic form. If a heart valve develops acute regurgitation that occurs suddenly, for example, from endocarditis, when an infection eats up the valve and causes a sudden severe leakage of blood across the valve, that can potentially lead to shock. And so in some cases, you can see shock when a patient develops sudden onset acute severe regurgitation of a heart valve. In contrast, chronic regurgitation occurs slowly over months or years. This does not lead to shock, but the danger of chronic regurgitation is that over time it will overload the ventricle and it will eventually lead to chronic heart failure. Among all the cardiac valve disorders, there are a couple of common themes in diagnosis and treatment that I'll mention on this slide. The first one is that for almost all cardiac valve disorders, the best initial test is a transthoracic echocardiogram. This is an example of a transthoracic echocardiogram on the screen. It allows you to visualize all the cardiac valves. You can measure the flow across the valve to screen for stenosis, and you can evaluate whether there is backward flow across a valve to evaluate for regurgitation. In general, EKGs are not helpful in valve disorders, and you should know this for board questions. Usually an EKG is not the right answer if you suspect a valve disorder. The only thing you can potentially see on an EKG is signs of chamber enlargement. So if a valvular lesion causes one of the ventricles to enlarge, you might see evidence of that, but you can't see anything about the valve itself. Another thing to know about valve disorders is that we only treat severe lesions. Echocardiography is so sensitive that for many patients you treat, they will have an echocardiogram and it will identify mild aortic stenosis or moderate mitral regurgitation. None of those lesions are ever going to be treated. We only treat severe valvular lesions. And one of the reasons we only treat severe lesions is because mostly valve disorders are surgical diseases, and we don't want to perform surgical intervention on the heart unless it's absolutely necessary. In some cases, valves can be surgically repaired, but in many cases, the valve has to be replaced. There are two options for replacing cardiac valves. The first one is to use a bioprosthetic valve. This is a valve with tissue that comes from a pig or a cow. The advantage of these types of valves is that they do not require anticoagulation. Blood clots do not form on these valves, but the downside is that they can develop wear and tear, and another valve can be necessary in 10 or 20 years. Another option for valve replacement is a mechanical valve. These valves are made of metal. The advantage is they tend to last a very long time, usually the patient's whole life, but the downside is they require lifelong anticoagulation. And then finally, there is a procedure called valvuloplasty, which involves breaking up fibrous connections between valve leaflets that can sometimes be done in cases of mitral or aortic stenosis, and we'll talk more about this later in this video. In general, valve disorders are surgical diseases and there is no medical treatment, but there are a couple of niche circumstances where sometimes we use medical therapy. The first one is in patients who have chronic valve disease and have developed heart failure. In those patients, we will use loop diuretics to reduce the intravascular volume and to treat patients who may have pulmonary edema. The second way that medical treatment is sometimes done is as afterload reduction. This refers to administering vasodilators to lower the blood pressure because in theory, this can improve the forward flow in regurgitant valve disease like aortic regurgitation or mitral regurgitation. In both aortic and mitral regurgitation, blood is leaking backwards, so if you lower the blood pressure, you can, in theory, cause more blood to flow forwards. And we will do this in rare circumstances, often when patients have acute regurgitation, but in general, clinical trials have shown little benefit for drugs that reduce the afterload, and this isn't commonly done. Before we talk about specific forms of valvular heart disease, let me briefly mention rheumatic heart disease. This refers to damage to the heart valves caused by rheumatic fever. Rheumatic fever is a complication of strep pharyngitis. It often affects children, and many children recover from acute rheumatic fever, but then many years later they will develop valvular heart disease, and that is referred to as rheumatic heart disease. In many cases of rheumatic fever, the symptoms are mild, so many patients who have rheumatic heart disease do not recall acute rheumatic fever symptoms. So just because a patient says, "I never had rheumatic fever as a child," doesn't mean they cannot have rheumatic heart disease. The most commonly involved valve in rheumatic heart disease is the mitral valve. Often the mitral valve develops stenosis or regurgitation, and we'll talk more about that later. And rheumatic heart disease is relatively uncommon in the United States. That's because children have ready access to antibiotics, so they are often treated for strep pharyngitis and they don't develop complications like rheumatic heart disease. Rheumatic heart disease is much more common in developing countries where there's limited access to medical care. And for this reason, in the United States, many patients who have rheumatic heart disease immigrated to the U.S. And in a board question, it will often be an immigrant to the United States who is the type of patient that presents with rheumatic heart disease. Carcinoid heart disease refers to heart disease associated with carcinoid tumors of the intestines. Carcinoid tumors are rare intestinal tumors that secrete serotonin, which is a neurotransmitter. For reasons that are poorly understood, these tumors often lead to fibrous deposits on the tricuspid and pulmonic valves. This can cause stenosis or regurgitation of the tricuspid or pulmonic valves. Importantly, carcinoid tumors are almost never associated with left-sided valve lesions like lesions of the mitral and aortic valves, and this is believed to be because serotonin is inactivated by the lungs. So the tumors release serotonin into the venous system where it travels to the tricuspid and pulmonic valves on the right side of the heart. But when the serotonin enters the lungs, it's inactivated, and therefore it does not reach the left side of the heart and cause disease of those valves. Once again, this whole process is poorly understood, but the bottom line is that patients with carcinoid heart disease almost never develop left-sided lesions. If you're going to see lesions from carcinoid heart disease in a board question, it's going to be either the tricuspid or the pulmonic valve. So for the rest of this video, I'll talk about specific forms of valvular heart disease, and I'll begin by talking about aortic stenosis. Aortic stenosis occurs when the aortic valve becomes fibrous and calcified. This is a picture of a stenotic aortic valve here. You can see that it's thickened and bumpy, and this valve is not going to open and close normally, and this patient is going to develop aortic stenosis. The physiologic problem with aortic stenosis is increased afterload. Remember that blood has to leave the left ventricle and enter the aorta by passing over the aortic valve. If the aortic valve is stiff and calcified, there's going to be resistance to flow out of the left ventricle, and that is increased afterload. In terms of hemodynamics, what happens in aortic stenosis is the left ventricular systolic pressure gets much higher than the aortic systolic pressure. This is called having a gradient across the aortic valve. So consider, for example, that a patient with aortic stenosis could have a left ventricular systolic pressure of 160 when normal is 120. In the aorta, however, the systolic blood pressure could still be 120, which is normal. This indicates a gradient of 40 millimeters across the aortic valve. In other words, the pressure in the left ventricle is 40 millimeters higher than the pressure in the aorta. Normally, this gradient is essentially zero because as soon as your pressure in the left ventricle gets just a teeny bit higher than the aortic pressure, the valve opens. But in patients with aortic stenosis, this gradient can get very high. Most patients who have symptoms of aortic stenosis have a gradient of at least 40 millimeters of mercury or more. I've listed some of the clinical features of aortic stenosis on this slide. The classic physical exam finding is the presence of a systolic crescendo-decrescendo murmur, heard best at the second right intercostal space, which is the aortic listening area. A systolic crescendo-decrescendo murmur is a murmur that increases in intensity and then falls in intensity between S1 and S2, which is the period of systole. The murmur often radiates to the carotids, especially in patients with very thickened valves. There are a couple of classic findings in patients who have severe aortic stenosis. The first one is the presence of a soft single S2. When the aortic valve is severely diseased, it has restricted leaflet motion. This causes the second heart sound to get very soft. A second finding in patients with severe aortic stenosis is called pulsus parvus et tardus. This refers to a carotid artery pulse that is weak and slow. If you place your fingers against the carotid artery in the neck of a patient with severe aortic stenosis, the carotid pulsation will be very weak and it will also be slow to rise to its peak force. This is called pulsus parvus et tardus, classic finding in severe aortic stenosis. In terms of symptoms, the first symptom that usually develops is angina. This is exertional chest pain. The second symptom is usually syncope, especially with exertion. When patients who have aortic stenosis exert themselves, they cannot raise their cardiac output like they need to with exercise. As a result, their blood pressure drops and they often faint. And then the final symptom that patients develop if aortic stenosis is left untreated is left heart failure. This carries the worst prognosis of all the symptom features of aortic stenosis. Most patients you will see with aortic stenosis are elderly. They have what's known as senile aortic stenosis. This is basically a wear and tear lesion of the aortic valve. Collagen breaks down, calcium gets deposited, and the valve ends up looking like this. Less commonly, patients have a bicuspid aortic valve that leads to aortic stenosis. This is a bicuspid aortic valve here. Because these valves do not have three cuffs, they open and close abnormally, and this leads to accelerated breakdown of the valve, and therefore aortic stenosis can occur at an early age. So a common age for senile aortic stenosis is about 60 to 80 or so. Many of my patients with aortic stenosis are in their 80s. Patients with bicuspid aortic valve disease, however, can develop symptoms as early as their 50s or sometimes 40s because their valve is not normal. And then finally, rheumatic heart disease can cause aortic stenosis, but this is very uncommon. The mitral valve is far more common. So aortic stenosis can be treated with traditional valve replacement surgery. In order to do that, the surgeon has to make an incision down the sternum and break the sternum and open the chest to remove the diseased aortic valve and replace it with either a tissue valve or a metal valve. But you should be aware that there is a very new and popular way to replace the aortic valve, and that's called a transcatheter aortic valve replacement operation, or a TAVR. In TAVR, there's no chest incision. The new valve is inserted into the arterial system and threaded up to the heart, just like shown in this picture here. The new valve is then inserted over the diseased valve, and the diseased valve is smushed against the walls, and the new valve is inserted to replace it. Patients like this because there's no chest incision and there's a faster recovery. The downside is that this is a newer procedure, so we don't know how durable these valves are going to be after they've been in for 10 or 20 years. Moving on, let's talk about aortic regurgitation. This occurs when there's inadequate closure of the aortic valve leaflets. This allows blood to leak backwards across the aortic valve into the left ventricle during diastole. Hemodynamically, this causes the preload of the left ventricle to go up and therefore the stroke volume to go up. It's high yield to know this. These are the hemodynamic changes of aortic regurgitation. And then another sort of basic science thing that's high yield to know about aortic regurgitation is that aortic regurgitation is a classic cause of eccentric hypertrophy of the left ventricle that can eventually lead to heart failure. When the left ventricle undergoes eccentric hypertrophy, the myocytes become longer, not thicker. They lay down more sarcomeres in series, so what you get is a dilated left ventricular cavity with a wall thickness that is normal. And I've shown this in this drawing. This wall is not thicker than normal, but the total mass of myocytes has led to a longer wall, a bigger wall, and therefore a dilated left ventricular cavity. This is called eccentric hypertrophy, and aortic regurgitation is a classic cause. The murmur of aortic regurgitation is classically described as a blowing, decrescendo diastolic murmur heard best at the lower left sternal border. So it's a diastolic murmur, so it's heard after S2. It's called blowing because it often sounds like someone blowing through a straw or a tube, and it's a decrescendo murmur, meaning that it fades in intensity over time in diastole. Some of the clinical features of aortic regurgitation are shown on this slide. These patients have blood that leaks out of the arterial system across the aortic valve and back into the left ventricle during diastole. This causes the diastolic blood pressure to fall, and it can become very low. So a low diastolic blood pressure is a hallmark of aortic regurgitation. For example, you may know that 120 over 80 is a normal blood pressure. A patient with aortic regurgitation could have a blood pressure like 120 over 40 or 120 over 50. And this will always be described in a board question, so this is an important clue if they show you a murmur that you can't identify. If the diastolic blood pressure is low, that strongly suggests aortic regurgitation is the cause of the murmur. Another classic feature of aortic regurgitation is a wide pulse pressure. So the pulse pressure is the difference between the diastolic pressure and the systolic pressure, and normal is about 40. In patients with aortic regurgitation, this pulse pressure gets very high, or otherwise referred to as wide. First of all, that's because the diastolic blood pressure gets low, as we just described. Also, these patients have a high cardiac output. Like we just talked about in the last slide, their preload is up and their stroke volume is up. This leads to a high cardiac output. So what's happening is the blood pressure is getting very low in diastole and then shooting up in systole because of the high cardiac output. And this is called a wide pulse pressure, a classic finding in aortic regurgitation. And because the pulse pressure is wide, these patients can develop symptoms from this. This usually doesn't happen in the modern era. This is mostly historical, before we had treatments for aortic regurgitation. So years ago, before there were surgeries for this condition, patients would have what's known as water hammer pulses. If you felt their pulses, they would be bounding. Some patients' head would bob because of the pressure going up and down in their aorta. And there were many, many other symptoms, but again, these are mostly historical and not seen in the modern era. I've listed some of the causes of aortic regurgitation on this slide. One of the most common is a dilated aortic root. If the root of the aorta becomes dilated, this pulls the leaflets of the aortic valve apart, and that leads to aortic regurgitation. Most commonly, people who have a dilated aortic root have hypertension, and that has stretched the walls of the aorta. Rarely they have an aortic aneurysm from some other condition like Marfan, and this can also lead to aortic root dilatation and regurgitation of the aortic valve. Historically, one of the most common causes used to be tertiary syphilis. So tertiary syphilis causes inflammation of the aorta, otherwise known as aortitis. So years ago, before penicillin was available, many patients with tertiary syphilis had an aortic root aneurysm and severe aortic regurgitation. This is rarely seen in the modern era. Another common cause is a bicuspid aortic valve. So we talked earlier about how patients with bicuspid aortic valves have that valve break down. This can lead to aortic stenosis, but it can also lead to aortic regurgitation. And many people have an isolated bicuspid aortic valve, but you should be aware, especially for your board exams, that bicuspid aortic valves are more common among patients who have Turner syndrome. They're also more common among patients who have coarctation of the aorta. Endocarditis can cause aortic regurgitation, and finally, so can rheumatic heart disease. Although rheumatic heart disease, as I've said before, almost always affects the mitral valve, and when it does affect the aortic valve, it almost always affects the mitral valve as well. So patients who have aortic regurgitation from rheumatic heart disease usually also have mitral stenosis or regurgitation as well. Moving on, let's talk about mitral stenosis. The vast majority of cases of mitral stenosis are caused by rheumatic heart disease. And the problem in terms of pathophysiology is that the mitral valve becomes stiff. Patients with rheumatic heart disease have fibrous tissue buildup on the mitral valve. They can also develop calcifications of the mitral valve. And as a result, those leaflets don't open and close normally. In terms of hemodynamics, what happens is the left atrial pressure will get much higher than the left ventricular diastolic pressure. Normally, these two pressures are essentially equal, but in order to open that stiff mitral valve, the left atrial pressure has to get very, very high. So for example, in a patient with mitral stenosis, the left atrial pressure could be 20, which is much higher than normal, and the left ventricular end diastolic pressure can actually be low. That's because the left ventricle is underfilling since blood can't get past that stiff mitral valve. And once again, this means there's going to be a gradient. In this case that I've shown here on the screen, there's a gradient of 15 millimeters, and that's abnormal. Normally, the gradient should be essentially zero. So just like we saw with aortic stenosis, in mitral stenosis, a pressure gradient builds up across the stiff valve. That's the hallmark of stenotic valve disorders. And then because the left atrial pressure gets so high, the left atrium can become massively dilated. So these patients commonly develop atrial fibrillation from having a big dilated left atrium. Also, in very rare cases, if left untreated, mitral stenosis can cause the left atrium to get so big that it compresses the recurrent laryngeal nerve and causes hoarseness. And there are other symptoms you can read about. They're mostly historical. They used to occur in patients with massive left atriums in the era before we could treat mitral stenosis. The most common symptom of mitral stenosis is dyspnea. When the left atrial pressure gets high, that pressure is transmitted backwards into the pulmonary capillaries, and this can lead to pulmonary congestion and even pulmonary edema. The murmur of mitral stenosis, which I talk about in more detail in the video on heart murmurs, is a diastolic rumble with an opening snap. So remember that blood moves past the mitral valve in diastole, so between S1 and S2, which is systole, there will be no murmur from mitral stenosis. But in diastole, you'll hear an opening snap, which is a sound caused by the stiff mitral valve, followed by a diastolic rumble. That's the murmur of mitral stenosis. Mitral stenosis is usually treated with valve replacement, just like many other valve disorders, but there is one special treatment for mitral stenosis you should know about, and that's called balloon valvuloplasty. This is used in cases of rheumatic mitral stenosis where the problem is just fibrous tissue causing the valve leaflets to become sticky. What you can do, as is shown in this picture, is you can insert a catheter with a balloon on the tip up through the right atrium, across the septum, into the left atrium, and across the mitral valve. You can then inflate a balloon, and this will break up all that fibrous tissue that is causing the valve leaflets to stick together. This is only done in cases of rheumatic mitral stenosis when there is little or no calcium deposition. It has to be purely a sticky fibrous tissue problem. So this is an alternative to valve surgery for some patients, and if the valve has the right characteristics, this can be done instead of replacing the valve. Next, let's talk about mitral regurgitation. Mitral regurgitation causes a holosystolic murmur heard best at the cardiac apex. It often radiates to the axilla. I talk about this in more detail in the video on heart murmurs, but this is going to be a holosystolic murmur, meaning the intensity of the murmur does not change and is the same throughout systole, which is between S1 and S2. When patients have mitral regurgitation due to some inherent problem with the mitral valve, we call that primary mitral regurgitation. When they develop mitral regurgitation from something outside the valve, that's called secondary mitral regurgitation. And primary mitral regurgitation is always caused by mitral valve prolapse. This is also called degenerative mitral valve disease or sometimes myxomatous mitral valve disease. In mitral valve prolapse, the mitral valve leaflets become stretched and they billow above the annulus of the mitral valve into the left atrium in systole. Let's take a look at this picture on the screen here. When the left ventricle squeezes, the mitral valve leaflets should come together like this, basically just at the level of the annulus, which is the ring surrounding the mitral valve. In patients with mitral valve prolapse, it looks like this. the leaflets are stretched and they billow up into the left atrium. This will allow some degree of mitral regurgitation to occur, and over time the mitral regurgitation can progress and become severe. Mitral valve prolapse causes a systolic click, so when these leaflets billow up into the left atrium, you can think of them as snapping and pulling tight on the chordae tendineae, and that causes a clicking sound in systole. And just an aside here, but don't confuse the systolic click of mitral valve prolapse with the opening snap of mitral stenosis we talked about in the last slide. The opening snap is a diastolic sound. The systolic click of mitral valve prolapse occurs in systole. And so in patients with mitral valve prolapse, they will have the systolic click, and that will be followed by a murmur of mitral regurgitation, because they almost always have some degree of mitral regurgitation. And this murmur of mitral regurgitation has some unusual characteristics. It increases with standing or Valsalva, and it decreases with squatting, and this is one of the ways you can identify this murmur with the stethoscope. And I talk about this in more detail in the video on heart murmurs. Some of the secondary causes of mitral regurgitation are shown on this slide. First of all, ischemia, if it damages the part of the left ventricle where the papillary muscles insert, can cause the papillary muscles to not function normally, and this can lead to mitral regurgitation. Patients who have dilated cardiomyopathy with a dilated left ventricle can have the mitral valve leaflets pulled apart. This leads to a form of mitral regurgitation called functional MR. And one thing that's super high yield to know about this is that functional MR sometimes gets better when diuretics are administered. So if a patient has a dilated cardiomyopathy and they become congested and they are in acute heart failure, the left ventricular cavity can become even more dilated than usual. Let's imagine that it's really wide like this. After you treat them with diuretics, that cavity size can shrink somewhat, and that can allow the mitral valve to function more normally. So in some of my patients with chronic heart failure, if they're admitted to the hospital in acute heart failure, their initial echocardiogram can show significant MR. But if the echocardiogram is repeated after they've been treated with diuretics, the amount of mitral regurgitation can be less. This is called functional MR, and it's high yield to know this because if they describe mitral regurgitation in a patient with heart failure, oftentimes they don't want you to send them to surgery right away. They want you to know that you need to treat them with diuretics first and then reassess the degree of mitral regurgitation. Hypertrophic cardiomyopathy is also a potential cause of mitral regurgitation. I talk about this in another video, but in patients with this condition, there is a high velocity of blood flow out of the left ventricle. This high velocity flow can tug on the anterior leaflet of the mitral valve and cause what's known as systolic anterior motion of the mitral valve. Over time, this tugging on the mitral valve leaflets can lead to significant mitral regurgitation. Endocarditis can cause mitral regurgitation. Rheumatic heart disease can cause mitral regurgitation. It often causes either mitral stenosis or mitral regurgitation. And then finally, there are a number of congenital causes of mitral regurgitation. Patients who are born with a cleft mitral valve have a mitral valve that has not formed normally. This often occurs in children who have what's known as an endocardial cushion defect. This is a defect of embryologic structures called the endocardial cushions, and it's very common in Down syndrome. So many children born with Down syndrome have a cleft mitral valve from an endocardial cushion defect, and they go on to develop mitral regurgitation. Let's talk about tricuspid regurgitation. Tricuspid regurgitation causes a holosystolic murmur. It sounds very similar to mitral regurgitation. The only difference is the location in which you hear it the loudest. Tricuspid regurgitation is heard loudest at the left sternal border. Mitral regurgitation is heard loudest at the cardiac apex. Most of us have a small amount of tricuspid regurgitation. This is normal. This is called physiologic tricuspid regurgitation. But there are some pathological causes. The first one is functional tricuspid regurgitation. This is what happens anytime the right ventricle becomes enlarged, for example, in patients with chronic pulmonary hypertension. So just like the mitral valve can leak when the left ventricle is swollen and distended in heart failure patients, the right ventricle can cause the tricuspid valve to leak when the right ventricle is enlarged. IV drug users classically get endocarditis of the tricuspid valve, and that causes tricuspid regurgitation. The reason is because they inject drugs into their veins, and the bacteria travel from their veins to the heart, and the first valve they encounter is the tricuspid valve. Carcinoid syndrome can cause tricuspid regurgitation, and then finally, there is a rare congenital anomaly of the tricuspid valve called Ebstein's anomaly, and children born with this condition always have tricuspid regurgitation. Tricuspid stenosis is a very rare valve disorder. It causes a diastolic murmur heard best at the left lower sternal border. So just like mitral stenosis causes a diastolic murmur, so too does tricuspid stenosis. The difference is the point on the chest where you hear it loudest. Tricuspid stenosis is going to be loudest at the left lower sternal border, whereas mitral stenosis is loudest at the cardiac apex. Tricuspid stenosis can be caused by rheumatic heart disease, although it always occurs together with mitral valve disease. It never occurs in isolation as tricuspid valve disease only. And much more common than tricuspid stenosis is for rheumatic heart disease to lead to tricuspid regurgitation. And then finally, carcinoid heart disease can cause tricuspid stenosis. Pulmonic stenosis is also a very rare cardiac valvular disorder. It can be seen as a congenital defect in children, so some babies are born where the commissures of the pulmonic valve, the commissures are the locations where the valve leaflet comes together. Sometimes those commissures are fused and sometimes the leaflets are thickened, so those children have evidence of pulmonic stenosis at birth. You can also develop pulmonic stenosis from carcinoid heart disease. And the murmur of pulmonic stenosis sounds just like the murmur of aortic stenosis. It's only heard in a different location. So the murmur of pulmonic stenosis is a systolic crescendo-decrescendo murmur, and it's heard loudest at the left upper sternal border. Pulmonic regurgitation is also a rare valvular condition. The most common cause is repaired tetralogy of Fallot. So if you look at this drawing on the screen, this is a drawing of what the heart looks like in tetralogy of Fallot, which is a congenital heart defect. Babies born with this heart defect have an aorta that is shifted over towards the right ventricle. It's called an overriding aorta. They also have a ventricular septal defect. In addition, they have obstruction to blood flow out of the right ventricle into the pulmonary artery. This is called right ventricular outflow tract obstruction, or RVOT obstruction. So when these babies have surgery and the RVOT obstruction is repaired, that almost always over time leads to stress on the pulmonic valve. And so as these babies grow up and become adolescents and young adults, they almost always develop pulmonic regurgitation that often has to be treated surgically. So in a board question, if they describe someone who had tetralogy of Fallot as a child that was repaired and they describe a murmur, they are almost certainly describing pulmonic regurgitation. Pulmonic regurgitation can also develop from endocarditis, but this is very rare. It can also develop as a component of rheumatic heart disease along with mitral valve disease, but this is also very rare. And the murmur of pulmonic regurgitation is very similar to the murmur of aortic regurgitation, only it's heard at a different location. The murmur is a diastolic decrescendo murmur. It's heard best at the left upper sternal border. I'll finish with this one slide on endocarditis prophylaxis. So endocarditis is infection of one of the heart valves, and sometimes patients contract endocarditis after dental work or surgical procedures because those procedures introduce bacteria into the bloodstream. So in some cases, antibiotics are given prior to dental work or surgical procedures, and this is known as endocarditis prophylaxis. Antibiotics are only recommended for the patients at highest risk of developing endocarditis, and that includes some patients with valve disease. The major indication for endocarditis prophylaxis is if a patient has had prior endocarditis. Those patients always need prophylaxis going forward after they recover from endocarditis when they have dental work or surgical procedures. The other group that needs prophylaxis is patients who have had a valve replacement and have a prosthetic valve. These patients also always get endocarditis prophylaxis. Importantly, however, prophylaxis is not indicated for patients with unrepaired valve disease. Years ago, all patients with valve disease got antibiotics, but this is no longer done. The newest guidelines say that antibiotics should not be given to any patient with unrepaired valvular disease, and it's important to know that for your boards. And that concludes our video on valvular disease.